Hi, this is Tom at the University of Iowa. It's a very interesting case we did recently. I just want to reference back to this paper that we wrote on using a parachute-like harness to position patients with severe kyphosis. You can see this patient that we did years ago. We really strapped him in and tilted him back, and we used those parachute-like straps across his shoulders to stop him from feeling like he was sliding down. Here's a fellow that we saw that had really severe ankylosing spondylitis, worse than the other patient, and we really had to tilt things way back for him to have a relatively flat head. Here you can see my position in the operating room. I was really only able to do his right eye because of the axis. The scope was kind of tilting back at the eye, and it was a very dense lens. It had been sort of pushed off for a bit, and so the lens was denser than usual. Here you can see the lens. We're doing hydrodissection here first. Because of the density of the lens, I thought it would be useful to use the miLoop. It also made it easier because of the relative sort of uncomfortable nature of how I was sitting. So here the miLoop is going in just under the capsule. This is a wonderful instrument for dense lenses, and I typically will use this to break the lens into 4 pieces. Here you can see behind the lens, the back of that loop is going, and now we're going to cinch the loop down and pinch this lens into 2 pieces. It tends to tilt up during this process, but we pushed it back down and rotated it a bit. We're going to make it into 4 pieces. Didn't quite rotate as much as usual, so I'm going to reach in there with a second instrument, in this case a dry cell, and just gently rotate those 2 pieces around to try to make it into 4 pieces that are relatively similar in size. Here once again we're pinching down with the miLoop. And now it's in 4 pieces which are left anterior. We're going to go in with the phaco. We're using Ozil and a fair amount of longitudinal ultrasound here, 20 to 25% with the maximal pedal down. And the Ozil's at 70%. The center of this lens was what was significantly dense, surprisingly dense, really. But the outside became increasingly less dense, as you would expect. So here we're just about to start, and we're going to put a single piece of acrylic in, which you can see is not folded perfectly. But all of a sudden it occurred to me, oh my gosh, I don't think there's any way that this fellow can sit for a YAG capsulotomy. And so it occurred to me that we needed to do a primary posterior capsulorhexis and maybe switch our lens selection. So we ended up putting this lens aside, and we secured the anterior chamber with some dispersive viscoelastic at the wound. And now we're going to use a 27 gauge needle with cohesive viscoelastic, and we're going to go right through the center of the lens, and we're going to push the anterior face of the vitreous back with that OVD, and we're also going to bow the posterior capsule forward a bit. This makes it act much more like a normal anterior capsulotomy. We're going to use these micro forceps from Duet, and you can see we got a posterior capsulorhexis about the same size as the anterior. What we're going to do now is something that I learned from Lisa Arbisser originally, and that is a bi-capsular capture. So we're going to place more dispersive viscoelastic at the wound to try to keep this sealed. We're going to place some across from us in the area of the sulcus, because we're going to place the haptics of this 3-piece lens in the sulcus. And so now we've got the leading haptic in the sulcus, and we're going to place the trailing haptic in the sulcus. And now what we're going to do is we're going to prolapse this all the way back so that it's behind both of these rexi, and so now we're just going to remove the residual material and remove the viscoelastic, which is anterior. The viscoelastic, which is posterior, tends not to cause much trouble, which is surprising, but I think it's because it's sequestered back there. The patient's done really well so far. This is Tom at the University of Iowa. Thank you very much.